Hi everyone, this chapter is going to cover therapeutic ultrasound. So we are going to hopefully preview this lecture now, and then we will get into lab and begin to practice actual application of ultrasound. So with ultrasound, what makes this a little bit different than the thermal modalities that we've talked about previously is that the heat that's produced with ultrasound is going to penetrate a little bit deeper than the types of thermal modalities we've talked about already. There are also some mechanical changes that can happen through use of ultrasound, so we'll talk about the differences in how you can set up those treatments. Ultrasound uses acoustical energy, which means sound. It takes sound waves and it converts it into heat or, again, these other mechanical changes that can happen underneath the surface. When most people think of ultrasound, they think of diagnostic imaging. They think of the pregnant mom going into and to see the picture of her baby. And it's the same sort of technology that we use for our ultrasound. We just don't see any pictures with ours. And so you will absolutely have to explain that to your patients. They're going to ask you what you see when you're doing the ultrasound, and you'll tell them we don't see anything. We don't get pictures with ours. What we primarily use ultrasound for is for deep tissue heating, and we can also use it for tissue destruction. And when I say tissue destruction, I mean tissue that we do not want there. So typically what we're talking about is like calcium buildup within muscles or tendons that is causing pain. Again, traditionally what we use ultrasound for in the clinic is musculoskeletal conditions where we want deep heat. So the effects of ultrasound then, if we're using it for deep heating, we're going to increase the rate of tissue repair, increase the rate of wound healing. We can increase blood flow. That is a thermal change. We can increase tissue extensibility. So just like we mentioned with heat, again, just heating an area isn't going to necessarily improve range of motion, but if we can increase the tissue extensibility and then go into stretching immediately thereafter, we should help to improve range of motion. As I just mentioned, with tissue destruction, we can break down calcium deposits. With ultrasound, we can reduce pain and muscle spasms, and we can also change cell membrane permeability. So ultrasound is produced by the machines, and it's actually produced by sending an electronic or sending a current through a crystal. So all the ultrasound heads, so on our machine, you pick up the ultrasound wand. Underneath the silver head, there's a crystal. It's a piezoelectric crystal housed in a transducer, so we call those transducer heads. We use synthetic crystals now, or man-made crystals, which are designed to give a more uniform dose of energy. And these crystals produce a positive and a negative electric charge when they contract and expand. They contract and expand when they are exposed to electricity. So we get this effect that produces ultrasound. It causes sort of a vibration in the crystal. And then this vibration in the crystal produces waves that are going to then enter into the tissue. So ultrasound travels in a sinusoidal waveform, which is that up and down continuous waveform. So it has the properties of wavelength, frequency, amplitude, and velocity. We're not going to get too much into that now. We will talk a little bit more about a few of those when we get into E-stim. But this acoustical energy is then going to be transferred from one molecule to the next by exchanging kinetic energy, but it does not cause any type of displacement. So the book talks about, think about like throwing a rock into a pond, into still water, and you have that sort of ripple effect that comes out. That's sort of how ultrasound works. It's going to be sort of concentrated in the area to which you're applying ultrasound, but then you're going to get effects that kind of move away from your treatment area a little bit as well. Ultrasound is not able to travel through air at all. So that's why we use a transmission medium. We typically use ultrasound gel, and that's how we're going to apply the treatments in the clinic and in lab when we practice. It's also very important that when you're applying an ultrasound that you place the gel on the person or on the ultrasound transducer, and then you keep firm contact between the transducer and the patient's skin. You don't want to expose the ultrasound head to air for any extended period of time. It can actually damage the crystal inside. Ultrasound also travels in longitudinal waves that occur parallel to the direction of the sound head. So if you place the sound head directly on top of tissue, the waves are going to come straight out underneath and penetrate down into the tissue underneath. This is going to sort of produce high and low particle density areas, which causes pressure fluctuations, which then can cause some physiologic changes in the tissue. So again, ultrasound can travel through solid and liquid medium, but it cannot travel through air, and it passes through soft tissue, again, as a longitudinal wave. What can happen if ultrasound would come in contact with bone? Then it will become a transverse or a shear wave, because ultrasound does not travel through bone very well. And so what happens is those longitudinal waves come down. If they strike bone, then they just start to shear off, and they start to build up in the area. Shear waves or transverse waves cannot travel through liquid very well, and so they start to build up in the area, and this can cause areas of increased heat build up, which will eventually become uncomfortable for your patient. So the ultrasound that's produced by the ultrasound head, again, we're going to have the energy coming straight out of the head down into the tissue. It's actually not produced by the entire head. The majority of the sound waves are going to be emitted from the center of the head, and then as you get closer out to the periphery, you're going to have less and less ultrasound energy coming from that area. Ultrasound waves can reflect, refract, penetrate, and be absorbed. There is some degree of divergence. So every time we hit a soft tissue interface, meaning we go from skin to adipose and adipose to muscle, you're going to lose a little bit of that ultrasound energy because it's going to be sort of reflected or refracted every time you change tissue types. The treatment area is going to be limited to the size of your ultrasound head. You're going to hear this probably a million times, but we typically try to keep our treatment areas no more than 2 to 3 times the size of our ultrasound head. Most of our machines have one ultrasound head that is fitted for them. We do have one machine where we have 2 different sizes. So you'll see that you can sometimes change the size of your ultrasound head based upon the size of the area that you're trying to treat. Again, this picture is just showing you that the majority of the ultrasound waves or energy is going to be coming from the center of your ultrasound head. And then as you get further and further out towards the periphery, you have less and less. Also, as you go down deeper into the tissues, you start to sort of spread out that ultrasound energy a little bit. This near area, near field or Fresnel zone is the portion that's used for therapeutic purposes. The effective radiating area, or ERA. This is, again, the size dependent on the size of your ultrasound head, and this is the part of the ultrasound head that's actually producing energy. So again, some ultrasound heads do come in different sizes, and then the crystals inside are going to have different frequencies as well. The ERA, again, is the area that's actually producing ultrasound waves, and we describe it in centimeters squared. It's always less than the actual size of the transducer face. Like I said, most of the energy is coming from the center of the transducer, and you're getting less and less as you get out to the periphery. Large ERAs are going to produce a more collimated or concentrated beam. What the part that's cut off on the bottom there, says that small ERAs are actually going to produce more of a divergent beam. So if you're using a very small ultrasound head, the energy is going to spread out over a little bit larger area. So frequency. Frequency is one of the 4 major settings that you are going to be responsible for setting into the machine when you set up an ultrasound treatment. It's measured in megahertz. It describes the number of waves that occur in 1 second, and the most common settings and the ones that we're going to use are 1 megahertz and 3 megahertz. 1 megahertz is low frequency. It is a little bit more divergent. 3 megahertz is a higher frequency. It is a little bit less divergent. And really how we determine frequency is based on the depth of penetration. So if we want to treat a deeper area, and this is purely based on anatomical location of the tissue in which you're trying to treat, you're going to choose 1 megahertz. If you're treating a more superficial structure, you're going to choose 3 megahertz. That's it, right? So all you have to do is think about what is the target tissue, what is our goal of treatment, what are we trying to treat, and then think about, is this more of a superficial structure or is this a deeper structure? If it's superficial, go with 3 megahertz. If it's deeper, you're going to go with 1 megahertz. As we get into lab, we'll go over a lot of different examples and how to sort of determine, am I going to choose 1 megahertz or 3 megahertz for my frequency? But frequency is one of the settings that you do need to set into the machine. All right, unstable cavitation. Let me skip ahead. I'm not sure why these continue to be out of order, but let's talk about what cavitation is first, and then we'll go back and hit what unstable cavitation is. So cavitation is the production of bubbles during ultrasound. So they're microscopic bubbles. They're very, very tiny. You cannot see them with the naked eye, but as you introduce this ultrasound energy into the tissue, tiny little bubbles are going to form underneath the surface. And actually, if you perform ultrasound in water, which we will talk about later, you can actually see some of the bubbles that will form with that. Bubble formation is normal during an ultrasound treatment. They're going to compress during high pressure and expand during low pressure trough. So as that crystal is expanding and contracting and introducing different types of frequencies or different frequencies of energy into the tissue, you're going to have bubbles that form that compress and expand. That is normal. That is stable cavitation. So what unstable cavitation is when those bubbles compress during high pressure, but then they actually collapse or burst during the low pressure, and this can actually cause some tissue damage. If our ultrasound machines are in proper working order, this should not be a problem. And we do have our equipment inspected on an annual basis, and that's one of the things that they're checking for, is that everything is working the way that it should, and there's not going to be any unintended harm to patients or to ourselves. So again, as long as your machine is functioning the way that it should, this shouldn't be anything that you typically need to worry about. So again, just going back to the previous slide. Oops, maybe. Unstable cavitation, again, is that oscillation and rupture of bubbles that's done, or that happens typically if the ultrasound is at too high of an intensity. So we haven't talked about intensity yet, but we will. It's one of the other 4 major settings that you're going to set into the machine. So again, as long as your machine's in proper working order and you're not using really high intensities with your machine, you should be just fine. Another thing is to just keep your transducer head moving. That's something that's really important during an ultrasound treatment. So as long as you're moving at a moderate pace, you're not using really high intensities, and your machine's properly inspected and working, you shouldn't have to worry about any type of tissue damage. Okay, so we talked about that. Power and intensity. Power is measured in watts, and it's produced by the transducer. We're going to talk about a few things here. So spatial average intensity, watts per centimeter squared. When we talk about intensity, we're going to always document it in watts per centimeter squared. So the big thing I want you to sort of take away from this is that that is an average intensity. So when you set your intensity into the machine in watts per centimeter squared, we're talking about an average that the patient is receiving over the course of treatment. There is a peak intensity. We're going to use what we call the beam non-uniformity ratio, or BNR, to figure that out. And there's whole separate slides about that coming up, so we'll talk about that a little bit more. But again, there's an average intensity that your patient's going to be receiving over the course of treatment. That's what you set into the machine. But there is a peak intensity. So there are times where the patient's actually receiving more energy than that. There's a spatial average temporal average intensity. That's a mouthful, but that is just basically saying like it's averaged over time. And then the half layer value is just, again, the energy that the patient's receiving at about half the total depth of treatment. There's not a lot that we really do as far as calculation of that goes. So duty cycle. Duty cycle is another one of the settings that you will choose when you are doing a treatment. And really there's only 2 settings that you will have to choose between. There's continuous and then there's pulsed. And we base this on, again, what are our goals of treatment? If we want to heat the area, then we're going to choose a continuous duty cycle, or a 100% duty cycle, meaning that ultrasound is emitted out of the transducer 100% of the time, and that's how we're going to produce heat. As I mentioned earlier, there are some mechanical effects of ultrasound or some non-thermal effects of ultrasound that we may still use. Say the person has an acute injury and we don't want to heat the area, but we do want some ultrasound properties for tissue healing and things like that, then we may choose a pulsed output. So the example is 25% duty cycle. Some machines go down as low as 10% duty cycle. So those are going to produce non-thermal effects. Again, this is going to be based on the stage of healing and our treatment goals for the patient. Continuous output or 100% duty cycle is going to heat tissues 5 centimeters or more deep. Again, previously we talked about thermal modalities like hot packs and whirlpools. Those typically get about 2 centimeters deep. So this is much deeper than that. And again, this is measured in terms of spatial average temporal peak intensity. So again, it's averaged over time and what your patient's going to feel with that. Pulse output is going to decrease the intensity and therefore reduce the thermal effects. The duty cycle is the actual amount of time that ultrasound is being applied to the tissues. It isn't going to entirely eliminate tissue healing, but it is going to minimize it. So if our goal of treatment is to do a non-thermal treatment, then we probably want to choose the lowest duty cycle that there is. Because again, the closer the duty cycle is to 100%, the more thermal it's going to be. The lower the duty cycle, the more non-thermal effects we're going to have with that ultrasound. So as I mentioned earlier, there is something called beam non-uniformity. It measures the degree to which the ultrasound beam is going to vary. It's the spatial peak intensity divided by the spatial average intensity. Don't worry about that. I'm not going to ask you to do any math problems with that. But I do want you to know that a perfect ultrasound beam with no peaks or valleys would have a BNR of 1:1. That doesn't happen, right? We know that ultrasound travels as a sinusoidal wave. There's going to be some peaks and valleys in that waveform. A BNR of greater than 8:1 would be harmful for the body. So the FDA requires that the BNR is marked on each unit and that the BNR is going to be less than 8:1 on every one of our units. If you look at our ultrasound machines, somewhere on, usually it's on the cord of the ultrasound head, there'll be a sticker and the BNR will be marked on that. It is going to be individual to each ultrasound head because it's based on the crystal that's inside each transducer. So you can see what the BNRs are for our machine. So again, this is basically just telling you sort of how off your machine can be. So how ultrasound travels through tissues. Again, it's going to travel through soft tissue as a longitudinal wave unless it would happen to strike bone, which is why we typically don't do ultrasound in the area of superficial bone, because then it would become transverse or shear waves and start to build up too much heat in the area. As you go again through each tissue interface, some energy is going to be reflected, some may be converted to transverse waves. Ultrasound can penetrate cell membranes, and then that causes the cell to acquire some kinetic energy, which kind of causes it to vibrate a little bit, and then that vibration gets passed to the next cell and the next one. Again, energy is reflected or refracted every time the ultrasound strikes an acoustical interface. So again, that change from skin to adipose, from adipose to muscle, muscle to nerve. Ultrasound will actually pass through adipose relatively easily. So before, when we talked about hot packs and cold packs, we mentioned that if a person has a lot of adipose, it might be difficult to get down to the muscular layer, which is what we're typically trying to treat. With ultrasound, because ultrasound travels very easily through water, adipose is made up largely of water, ultrasound will travel very easily through adipose. So adipose does not serve as the same kind of insulator with ultrasound as it would with hot and cold packs. So sometimes with our patients who have a lot of adipose, ultrasound might actually be a more beneficial treatment for them. So you guys don't have to memorize any of these numbers. This is just a chart to sort of demonstrate. This is the percent reflection. So as you go from water to soft tissue, we're only losing about 0.2% of the ultrasound energy. Soft tissue to fat, 1%. So again, ultrasound travels very easily through adipose tissue. Soft tissue to bone, we're going to lose about 15 to 40%. So that means that energy is sort of building up as transverse or shear waves. And then soft tissue to air, 99.9%. Ultrasound does not travel through air. A standing wave, this is the collision of two waves of equal frequency and speed that travel in opposite directions. It cannot be transferred to any other type of energy. It's focused in a confined area. And again, this is where we can have an increased risk of tissue damage. So this can be avoided by keeping the ultrasound head moving. And again, we're going to talk about this more. We're going to practice this as we're doing the ultrasound, but it is important to keep the ultrasound head moving. We don't want to just hold it still over the same area because then we can create standing waves. Periosteal pain is when ultrasound energy reflects off bone. The periosteum, remember, is the outer covering of bone. It has lots and lots of nerve endings in it. And so that's the part that's highly sensitive to pain. If you break a bone or ever had a broken bone, it's typically because of damage to the periosteum that you actually feel the pain. The bone itself doesn't have a lot of nerve endings in it. But if ultrasound begins to strike bone, it'll strike the periosteum first, and the irritation can cause sort of like a deep aching sensation. So we do need to use caution if we're ever applying ultrasound over a superficial bone. And like I mentioned earlier, we typically try to avoid any area where there is superficial bone with ultrasound. Just as a little side note, they do sometimes use ultrasound to diagnose stress fractures because it's difficult to detect stress fractures. They don't typically show up on x-rays very well. So what they'll do is they'll ultrasound over the area where there is a suspected stress fracture. And if the person reports that achy type of pain, then they are often diagnosed as positive of having a stress fracture in the area. Attenuation is scattering and absorption of ultrasound waves as they go deeper and deeper into the tissue. Again, this chart just shows you a little bit about how ultrasound is absorbed. So things that have high water content like blood, fat, nerves, muscles, ultrasound travels relatively easily through those. As we get to like tendons, cartilage, and bone, ultrasound is not going to travel as easily because there's more protein in these, less water. So again, anything water-based, ultrasound should travel relatively easily through. Again, thermal applications with ultrasound, these are going to cause all the same effects that we talked about with the thermal lab. So all those physiologic effects of heat, the vasodilation, the increased nerve conduction velocity, all of that stuff, the same is going to hold true with a thermal ultrasound. With a non-thermal ultrasound, we're going to have, again, some mechanical changes that are going to happen underneath the surface. We're going to have some thermal effects. Again, we can't completely eliminate the thermal effects, but we can certainly minimize them by choosing the lowest duty cycle that our machine offers. The effects are going to be limited, again, to the size of the ultrasound head, and our treatment area should be no more than 2 to 3 times the size of the ERA. Again, remember, the ERA is even a little bit smaller than the ultrasound head itself because of the concentration of the energy coming from the center of the ultrasound head. The smaller the area you treat, also the greater the temperature increase. So do be careful if you're treating a really small area. You can have a lot of increase buildup of ultrasound energy, so a lot of buildup of heat in that area. Again, the effects are going to be dependent on the duty cycle and the intensity. The higher the duty cycle, the more thermal effects, the closer to 100%. The higher the intensity, the greater the magnitude of those effects. So we'll talk about intensities and choosing those. But again, the higher the intensity, the more quickly the person is going to feel those thermal effects. Non-thermal effects, so why we would use a non-thermal ultrasound is typically for people who have acute injuries. So we're going to use a pulsed output. Like I said, a lot of our machines actually go as low as 10%. So that's what I would choose if I'm doing a pulsed ultrasound. And we'll talk about intensities. The book says you can use a normal intensity or a continuous duty cycle with a low intensity. My thought on this is that if I am really trying to avoid heating an area, I'm going to choose a pulsed output. And I'm also going to choose a low frequency as well because I'm going to do everything in my power to make sure that I'm not heating that area. So thermal effects are going to depend on your duty cycle. Again, we're going to choose 100% or continuous output for that. Our output intensity, the frequency, the tissue type, the size of the treatment area, which again, we're going to keep to 2 to 3 times the size of our ultrasound head, and the speed at which the sound head is moved. If you move the ultrasound head really quickly, really rapidly, you're not going to give heat time to build up. If you move it too slowly, you're going to give heat a lot of time to build up, and you could potentially make the patient uncomfortable. So again, we want to try to find a moderate speed with our ultrasound head. Again, thermal effects of ultrasound are going to be the same as everything that we've talked about with heat, but we are going to be able to heat a deeper area. It is going to be a smaller area. Ultrasound tends to be more concentrated. Muscles, which again are typically our target treatment area, they do have a lot of vascularity. So the tissue temperature increase is not going to be as great because cooler blood is going to be constantly moving through and it's going to wash out the blood that we're heating with the ultrasound. So pulsed ultrasound, what this is going to do and why we use that, again, this is with acute injuries typically, is it's going to stimulate the healing process. So the thought behind this, or the theories behind this, is it's going to stimulate phagocytosis, which is those the white blood cells that are sort of coming in and cleaning up the area, the mess that has been created by that acute inflammatory process. It's going to increase the quantity of free radicals. It's going to alter cell membrane permeability, and it's going to increase fibroblastic activity, which helps to lay down that healthy granulation tissue and helps to promote that early scar formation. Pulsed ultrasound is also believed to sort of accelerate that inflammatory process, which helps us get into that proliferation stage a little bit sooner. So again, everyone wants out of that acute inflammatory stage as quickly as possible. That's why we rest and we ice and we try to get through that so that we heal even more quickly. And so pulsed ultrasound is supposed to help with that as well. So as far as the response or the injury response process and the effects of ultrasound, ultrasound, again, can help to increase membrane permeability. It can increase local metabolism if you're using a thermal treatment especially, increase histamine release and increase rate of protein synthesis for a non-thermal treatment, which again, even with a thermal treatment, you're going to get some of these non-thermal effects as well. If someone has inflammation, we don't want to use a thermal ultrasound at that point. If we used pulsed ultrasound, it can help to sort of accelerate that inflammation stage, get us to proliferation a little bit faster. It'll increase the release of fibroblasts, increase tendon tensile strength, so make it stronger, that granulation tissue that's being laid down, and increase the rate of collagen synthesis, which again speeds along the healing process. As far as blood and fluid dynamics go, a continuous ultrasound, which again is going to heat the area, will increase local blood flow for up to 45 minutes after treatment. So that increased temperature is going to increase blood flow and cause local vasodilation just in the area. Ultrasound can be used to control pain. It can change the conduction of nerve fibers and elevates the pain threshold. It can also increase blood flow to the area, so if there is ischemic pain, this should help with that. And it can also help with muscle relaxation, which can help to decrease pain as well. So same sort of goes for muscle spasm. A thermal ultrasound heat can help decrease a muscle spasm, which can help to break that pain spasm pain cycle. It can also, ultrasound can also alter nerve conduction velocity, and increase blood flow to decrease the noxious stimuli in the area. So again, all of these can work together to help relax the muscle. One of the big things we use ultrasound for, again, is to increase tissue elasticity. So ultrasound is going to heat collagen-rich tissues like tendons, ligaments, fascia, scar tissue. Some studies have shown that using a 3 megahertz ultrasound, which is again our more superficial setting for frequency, gives us about a 3-minute window of effective stretching time. It is believed that doing a deeper ultrasound at 1 megahertz may actually cause that heat to last a little bit longer. You do need repeated exposure to heat and stretch, right? We can't expect to do one ultrasound, stretch the person, and they're cured, right? We need to continue to do that. And if possible, and we're trying to elongate the tissue, if you can actually put the person in sort of a stretched position and elongate that tissue while you're doing the ultrasound, then that might be even more helpful because you're getting a stretch throughout the whole treatment as well. So wound healing. Wound healing is another indication for ultrasound. They've done lots and lots of studies on this and found that superficial wounds have responded favorably to ultrasound when they were performed daily over a 2-week period. In another study, they looked at pressure ulcers or bed sores that were treated with ultrasound. The settings that they used were 3 megahertz, so they used a superficial setting, a 20% duty cycle, so they kept it pulsed, so they weren't trying to heat the area, and they used low intensities of 0.1 to 0.5 watts per centimeter squared. They did the ultrasound around the wound, and I'll talk about how you can sort of treat wounds, and then use that with standard wound care techniques. And they found that the patients who had the ultrasound healed faster than the patients who just got the standard wound care techniques. So there's really 2 different ways you can ultrasound around a wound. One is to ultrasound the peri-wound area, meaning you just kind of go around the outside of the wound area. The other way is what they're showing in this picture, where they're using like a bio-occlusive dressing here. So they have a protective barrier over the wound, and then they ultrasound right on top of that. In the absence of this, you can actually use saran wrap. So you can put that over the wound, and then you can ultrasound right on top of the wound. Phonophoresis. I'm going to guess that not many of you have heard of phonophoresis. This was around a little bit when I first started practicing. It's kind of gone by the wayside. It's been basically replaced by iontophoresis, which we're going to do a whole separate unit on ionto later. Iontophoresis is considered sort of like a needleless injection. It's using electric current to drive medication through the skin. So what phonophoresis is using ultrasound to try to drive medication through the skin. So this used to be a pretty popular technique, but then with the advancement of iontophoresis, that has sort of taken its place here. So the idea behind phonophoresis is that ultrasound will help to sort of open some of the pathways that will allow medication to diffuse deeper into the tissue. Ultrasound will also help to spread the medication over a larger area than you could with an injection. It's non-invasive, so you don't have to get a shot or an injection, which most people would prefer that. And it also bypasses the liver, meaning that you don't have to take a pill that's going to be processed by your body, right? So we can actually apply the medication to the area that needs it. With ultrasound, we can penetrate up to about 6 centimeters with the medication. Some things that will affect the depth of penetration of medication using phonophoresis are the skin thickness. So it's difficult to treat areas of really thick skin composition, hydration, vascularity, which we really don't have any control over. And then there was a thought about preheating the area with moist heat, which would increase local blood flow and kinetic energy, hopefully open up the skin pores and allow the medication to travel through a little bit more easily. The only problem with that is that heat also causes vasodilation, and so the blood is going to be flowing more readily through that area, and it's also going to wash away some of your medication as well. So the medications that we use with phonophoresis, we have to choose them carefully. We have to choose medications that have a small enough molecular weight that it can actually fit through the skin pores. We combine it with the ultrasound gel so that it travels through the tissue. And you can't use a medication that will actually reflect the ultrasound energy, which is what was really done for a really long time. Because when phonophoresis was popular, what we often used it with was thick white corticosteroid creams. And so what we later found out is those thick white creams that we were putting on was actually reflecting all the ultrasound energy. So none of it was really being absorbed by the tissues. So any medication that was getting into the tissues was basically just getting there by diffusion. So you might as well have just rubbed the medication on the skin and not used an ultrasound at all. We found now that gel-based medications do work much better. And you can do the invisible method where you do actually rub the medication into the skin first, and then you perform an ultrasound on top of it to try to drive the medication down a little bit deeper. So the efficacy of phonophoresis really hasn't been proven. We did actually prove that what we were doing didn't work so well, so then we kind of stopped doing that. And then, like I said, ionto came around, so now we pretty much just use that instead. So the ineffectiveness of phonophoresis was, again, usually related to the conductance of the medication that we were using. Dexamethasone, which you may have heard of because that's the probably most popular medication that we use with iontophoresis, can actually be used for phonophoresis as well. It transmits 95 to 98% of ultrasound energy, so it can actually be driven down through the skin with ultrasound as well. Like I said, hydrocortisone is a poor transmitter. Those thick white creams just do not work very well. And they are looking at developing some new methods with low frequency sound generators to be able to use with medication as well. All right, so our contraindications for ultrasound. These are important to know. We're not going to do a thermal ultrasound if the person has any contraindication to heat. So all of those things that we talked about with heat, your people with poor sensation, poor circulation, we're not going to want to heat them, or at least be very careful when we heat them. So again, the impaired circulation, ischemia, sensory deficit, we want to be very, very careful with those patients. We don't want to do an ultrasound over an area of DVT. Like I said, if someone has a blood clot, we're typically not going to do much with them at all until they get that medically managed. But if they have a blood clot, you certainly don't want to ultrasound around it, because ultrasound is going to cause those little vibrations. We don't want to vibrate that blood clot loose and possibly send it, again, somewhere important like the lungs, the heart, the brain. We don't want to ultrasound over an area of infection. Again, we could possibly spread it somewhere else. So same thing goes for cancer. Not sure why we would, but we don't ever want to ultrasound over fluid-filled cavities like the eyes, the heart, the skull, the genitals. Pacemakers are going to be a contraindication. You're going to find that they make a lot of the contraindication lists, as does pregnancy. And a lot of that is that, and I get asked this a lot, will pregnant women go for ultrasounds? Why would we not want to ultrasound them? Again, this is repeated exposure. We're not exactly sure what it's going to do, and we don't want to take any chances with it potentially doing any harm. So we're not going to do ultrasounds, especially over the back or the abdomen of someone who is pregnant. We don't want to ultrasound over a stress fracture. As I mentioned earlier, ultrasound can be used to diagnose a stress fracture. It often causes pain over that area, so we're not going to ultrasound someone who has a known stress fracture. And then we're also not going to ultrasound right over the vertebral column. That is an area of superficial bone. It can cause periosteal irritation, so we're not going to ultrasound right over that area. That being said, we can do ultrasounds over the cervical region and the lumbar region, but we are typically ultrasounding the muscles in that area, and if you need to cross from one side over to the other, that is completely fine. We, again, just don't want to hang out over the vertebral column. Your book always ends with any controversies in treatment. With ultrasound, the efficacy is still questioned, meaning there's people out there who say ultrasound just doesn't work. There's some that say it does. It is somewhat questionable. There is irrefutable proof that ultrasound will increase tissue temperature. There's plenty of research out there that shows this does indeed happen. It may vary a little bit between units, or one machine to another, but ultrasound can certainly raise tissue temperature. A lot of the published studies have flaws. We'll get in, there's another slide that talks about some of the things that are commonly done wrong with ultrasound studies. Again, thermal effects are pretty well supported. It's the non-thermal effects where we still need some more research. Again, there is good evidence out there that definitively supports that if ultrasound is done properly, it is capable of vigorously heating a small area. Again, the common errors in a lot of studies are that they're not using appropriate frequencies for the area that they're treating. Frequencies, again, remember, are 1 megahertz or 3 megahertz. 1 is deep, 3 is superficial, so they're not matching them up correctly. They're trying to treat too large of an area. So if you're trying to treat an area that's too large, you're going to scatter your heat and you're not going to get those deep heating effects. If you're using too low of intensities, again, you're not going to build up heat in the area. They're not using appropriate coupling medium, or they're moving the sound head too rapidly to actually build up heat. All right, so that's what I got for this. Like I said, we will go over a lot of the stuff in lab. Again, we'll go over the settings that we'll choose for ultrasound treatments. So make sure that you bring your clinical application of ultrasound lecture to lab with you. I'll see you there.